The subcommittee will come to order. The chair will recognize himself for an opening statement. Medicare and Medicaid are critically important programs that millions of Americans rely on. These programs are in trouble. Doing nothing is not an option. Doing nothing is unfair, particularly to those who can't afford any other options. Doing nothing is irresponsible. But in the last few years, those who have proposed solutions have been viciously attacked by special interests and their allies on Capitol Hill. When the House passed a budget that charted a path to saving Medicare, many on the other side accused us of trying to, quote, end Medicare as we know it, end quote. But they offered no solution of their own. Let me be clear. The status quo spells doom for every American who relies on Medicare or Medicaid for their health care. Both parties need to work together to modernize these programs so they can survive. Today's hearing is designed to get an accurate picture of the fiscal challenges facing Medicare and Medicaid so we can preserve these programs for the populations they were designed to serve. Without defining the problems these programs face, we cannot assess whether they are serving current beneficiaries in the most efficient and effective manner possible, and we cannot strengthen and save them for future generations. The Medicare program served 49 million beneficiaries in 2012, and as was noted in a previous hearing, has been on the Government Accountability Office's high-risk list since the list began in 1990. According to the latest Medicare Trustees report, Medicare will be insolvent no later than 2024, but as soon as 2017. More recent estimates have predicted insolvency as soon as 2016. That's 3 years from now. Doing nothing is not an option. Slogans such as "hands off my Medicare" and the past refusal of some on the other side of the aisle to even discuss changes to the program will lead to Medicare's collapse. We can begin modernizing these programs now, or we can do nothing. If we do nothing, Medicare will not be there for our children and grandchildren. In fact, if we do nothing, Medicare as we know it will not be there for today's seniors in a few short years. Nearly 60 million Americans are currently enrolled in Medicaid. While Medicaid spending accounts for nearly 1/4 of most state budgets, in my home state of Pennsylvania, it's approximately 1/3 of the entire state budget. Should Pennsylvania choose to expand the program under the Affordable Care Act, approximately 60% of the Commonwealth's budget will go to welfare spending, including Medicaid, unfairly crowding out funding for roads, schools, and public safety. Medicaid costs to the states are expected to grow by nearly $400 million in the next fiscal year, and these costs do not include any cost associated with an expansion. Currently, 1 in 6 Pennsylvanians receives Medicaid benefits. If the governor chooses to expand Medicaid in the Commonwealth, 1 in 4 Pennsylvanians will be on the Medicaid rolls. And this is not just a problem for Pennsylvania. The next 10 years of federal Medicaid spending will be twice the amount spent in the last 45 years. This is completely unsustainable. Medicaid was designed as a safety net for our nation's poorest and sickest people. States are already struggling to serve this core population, and Washington certainly doesn't have extra money lying around either. For a system that is already under tremendous strain, how will adding millions of young, able-bodied adults to Medicaid affect our ability to care for our country's poorest and sickest citizens? With both Medicare and Medicaid, we face a fundamental issue of fairness. Is it fair that young people are paying into Medicare when, as now, the program will not be for them when they retire? Increasingly, doctors simply can't afford to treat Medicaid patients. Is it fair that the President's health care law will force millions of disabled and sick Americans to compete with able-bodied 25-year-olds for appointments with those doctors who will still see them? I look forward to hearing from our witnesses today not just about the challenges we face in preserving these programs, but also their solutions to modernize and save, Medicare and Medicaid. Thank you. I yield. That concludes my time. The Chair recognizes the ranking member of the Subcommittee on Health, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Chairman Pitts. Today we will examine Medicare and Medicaid, the safety net programs that afford our seniors, disabled, and low-income Americans access to quality health care. Ensuring the long-term fiscal stability of these programs has been and continues to be a priority of my work in Congress. Budgets are about more than numbers and dollars. They're real-life expressions of priorities, of choices, and of values. And these choices have an impact on the lives of millions of Americans, not just for the fiscal year each budget covers, but for future years and future generations. Now, I know that growing deficits are not good for the future either, but we cannot reduce the deficit and give tax cuts to the wealthy on the backs of our most vulnerable Americans. What Republicans want to do when they talk about painful cuts in the name of fiscal responsibility is to cut the structural foundation of our safety net programs. They want to block grant Medicaid under the guise of state flexibility. They want to decrease the Medicare rolls and turn seniors' health over to insurance companies. But these changes do nothing to tackle health care costs. They simply undermine the program's guarantee of access to care. So let's be clear and let's use facts. We have deficits because of 2 unpaid wars, years of unpaid tax cuts to the rich, and a deep recession. Meanwhile, revenues as a percent of GDP from 2009 to 2012 were at the lowest levels seen in 40 years. But because Republicans made it clear that they will not consider any further changes in revenues, not even to get rid of egregious tax breaks for the wealthiest Americans, their only idea for addressing our budget challenges associated with health care is to shift costs and risk onto seniors and to the most vulnerable Americans who depend on Medicare and Medicaid for health security. Now, I agree there's more that can be done to make the health care system more efficient and economically sustainable. The reality exists that an aging population means more people will rely on Medicare, and millions of the uninsured will now have access to health care through Medicaid because of the Affordable Care Act. But there are common sense reforms that I believe Democrats and Republicans can agree on that would bring greater value into our health system and that don't include cost shifting. The Affordable Care Act includes a number of provisions designed to both reform health care delivery and improve the quality and efficiency of health care. This, I believe, was a huge down payment on reforming the way Medicare and Medicaid deliver care. And we're already seeing it pay off. Over the last 3 years, Medicare costs per person have grown 1.3% slower than growth in the overall economy. And that is a reversal of decades of rising costs. Healthcare reform was entitlement reform. The ACA decreases the deficit and promotes efficiency and quality. So let's build on that work. Let's have a productive and fair conversation about how to bring more value into these programs and not eviscerate them. So, Mr. Chairman, the issue is not whether we reduce the deficit, but how we do so, and that conversation must include a discussion about revenues. I now yield whatever time I have to the gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Pallone. I want to say a word about Medicaid, and I hope that my good friends, our good friends on the other side of the dais, understand that leaving so many Americans without any insurance coverage has severely damaged their health as individuals and our economic health as a nation. The ACA makes the investment we need to correct this. Cutting $810 billion and restructuring Medicaid as a block grant is the absolutely wrong way to go and will have catastrophic long-term economic and health consequences for the nation. I can tell you firsthand what it's like because we in the territories have always had to struggle under Medicaid caps. Benefits and services have to be limited. Eligibility for us is well below the FPL. We can't provide long-term care to all who need it, and we don't get dish payments. Our governments end up taking up the slack, and our hospitals are already in crisis. I don't wish that on anyone, not even those who think they want Medicaid as a block grant. Your constituents deserve better, and your districts, states in this country need us to do better. The best way to reduce Medicaid costs is by creating good jobs and by fully implementing and funding the Affordable Care Act, not going back to the Bush-era policies that increase poverty and the Medicaid rules in the first place. I yield back the time. Mr. Ranking Member.
Chair thanks the gentleman. And at this point, recognize the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for an opening statement.
I thank the chairman for the recognition. We've all heard the figures. We hear them literally every week. 10,000 baby boomers become eligible for Medicare every day. At the inception of Medicare, 5 workers supported every beneficiary. Today there are 3. By 2030, there will be only 2. The cost pressures are increasing, and we risk the ability to provide access to services for beneficiaries. Spending in Medicare alone is projected to double over the next 10 years. The estimates are almost $40 trillion in unfunded liabilities, leading to insolvency by 2017. The Medicaid program, begun in 1965, created to serve as a safety net for a very narrow population of 5 million very low-income Americans. The program has grown. Now it covers over 40 million Americans. Under the Affordable Care Act, it will grow even more. 25 million new individuals, 65 million total Americans. It's counterintuitive given the existing problems that already serve as a barrier to accessing care. Our country is $16.5 trillion in debt. The President came to the House of Representatives last week and explained that he didn't think that was a pressing problem. I disagree. I think that it is. The issue is no one knows when it becomes a crisis. No one knows when the federal government takes $110 billion down to the Bureau of Public Debt some Tuesday at noon to sell, and no one shows up to buy. What happens next? Likely the interest rates rise. Do they go up a little bit? Do they go up a lot? If they go up more than a little bit, what happens to the debt service on the national debt, on that $16.5 trillion? You talk about mandatory spending. That's mandatory spending, spending that's not available for any other program. When we talk about crowding out other programs, that's what's at stake. And then we saw this weekend in Cyprus, where the government of Cyprus decided to take very radical action because they felt the pressure from the debt crisis that they are facing. I'm not saying that's what's in store for the United States, but you certainly understand that given the world situation, that we do need to pay attention. Our debt does matter, despite what the President disclosed to us last week. So $16.5 trillion in debt. Medicaid costs are escalating $400 billion a year. States, even those states that have rejected expansion, like my home state of Texas, will be pressured to save money by reducing benefits or further cutting provider reimbursement. Now think about that for a minute, what that means. We always talk about wanting to give patients access to high-quality, accessible care. How's it going to be high quality? How's it going to be accessible if you keep cutting provider reimbursements and reducing benefits or increasing waiting lines to get that care? Spending in Medicare and Medicaid is not proportional to the distribution of beneficiaries. Over $400 billion is spent annually on 50 million Medicare beneficiaries. More than half of that amount is for the 10 million individuals eligible for both Medicare and Medicaid. Nearly 1 in 10 of those so-called dual eligibles have 5 or more chronic conditions, and well over half have mental or cognitive impairments. The most expensive dual eligible patients, almost 1.5 million, comprise 70% of the total expenditures for that group. So we need to address cost, but the underlying system structure is something that needs to be looked at as well. We must consider reforms that address the structure of this very critical entitlement program. Our heads have been stuck in the sand for too long. We know that the structural and fiscal problems exist. We know that they must be dealt with. The only question is how long will America and Americans tolerate staring at these problems without fixing them for future generations? I thank the chairman for the yielding, and I'll yield back the balance of my time.
Chair thanks the gentleman, and now recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today we have a hearing on the entitlement programs and the economy. There's an implication here that we have to choose one or the other. Unfortunately, in the name of fiscal responsibility and balancing the budget, we're often presented with what I believe is a false choice between securing our nation's fiscal health and ensuring the health of older, disabled, and low-income Americans. There are different paths we can take to ensuring long-term fiscal health of Medicare and Medicaid. The Ryan budget proposal that's going to be on the floor this week, what my Republican colleagues and their witnesses propose in our hearing today, are fundamental structural changes in the programs, which through premium support and privatization for Medicare and block grants for Medicaid don't hold down the cost, but simply shift them to beneficiaries, providers, and states. This path, as I said, doesn't lower costs. It shifts costs in a way that undermines the program's guarantee of access to care. The alternative path that we began in 2010 with passage of the Affordable Care Act is to reform entitlement programs through delivery system reform that improves both efficiency and quality. The Affordable Care Act improves access to preventive care that saves dollars and lives. It includes incentives to reward physicians and other providers for better coordinating care and improving health. It has also included policies to cut waste and inefficient care. Health reform is entitlement reform. It is this kind of reform that builds a better health care system for all Americans. At the same time, it lowers costs and helps support the long-term sustainability of our public health care programs. Medicare and Medicaid aren't ballooning out of control. These programs are amazingly efficient. Over the next 10 years, Medicare per capita costs are expected to grow at 5% per year, as opposed to 6.9% in private insurance. On the Medicaid side, the Congressional Budget Office estimates projected Medicaid spending dropping by $200 billion through 2020, and the CMS actuary predicts spending will grow no faster per beneficiary than private insurance. The problem is the numbers and aging of our society. In the coming years, we'll see a growth in the number of people who need Medicare and Medicaid. For Medicare, it is because of the retirement of the baby boomers, and many of these Medicare beneficiaries will also rely on Medicaid. Currently, dual eligibles are 15% of the Medicaid population, but account for nearly 40% of expenditures. In Medicaid, millions of Americans who were previously shut out of having insurance, particularly the working poor, will now have access to coverage beginning in 2014. More people clearly means more costs, but the solution should not and cannot be simply to shift costs to states and beneficiaries, but to continue our efforts to improve the value we get from our programs in a thoughtful and sensible way. Did we know there was going to be a larger population coming on Medicare and Medicaid? Of course we've known this. We've known that we've had a baby boom population. But rather than put money aside to take care of that population, we spent it on 2 wars without any funding for them. We spent it on tax breaks for the upper income without paying for them. We worked ourselves into a deep debt, and now the money is not there that we anticipated to use for these programs. Well, the Republican budget slashes away at the programs that families need most. The Republican budget is built on a hoax. On the one hand, they say it balances in 10 years. On the other, they say repeal Obamacare. The fact is they repeal all of the benefits of Obamacare, including improvements to Medicare, like filling in the Medicare Part D donut hole and adding no-cost preventive services. But then they turn around and keep the very Medicare cuts and taxes from the Affordable Care Act that Republicans campaigned against. Revenues need to be on the table. I don't think most Americans will say we know there are going to be 70 million more seniors. And Medicare, we hope you can make do with dollars that supported only half that number. We need to eliminate the tax perks for the wealthiest. It's unjust, especially if at the same time we're talking about cutting holes in the safety net for the elderly and the poor. Yield back my time.
Chair, thanks to the gentleman. That concludes the opening statements. The title of our hearing today is Saving Seniors and Our Most Vulnerable Citizens from an Entitlement Crisis. The hearing was scheduled on March 6th. It was canceled due to snowstorm. I want to thank the witnesses for arranging their schedule to accommodate our hearing today. Our panel is comprised of 3 distinguished witnesses. First, Mr. James Capretta, Senior Fellow, Ethics and Public Policy Center. Secondly, Mr. Joshua Archambault, Director of Healthcare Policy and Program Manager for the Middle Cities Initiative, Pioneer Institute. And thirdly, Dr. Judy Fader, Professor of Public Policy, Georgetown Public Policy Institute. Your written statements will be made a part of the record. We ask that you summarize your testimony in a 5-minute opening statement. The Chair recognizes Mr. Capretta for 5 minutes for your opening statement.
Thank you, Mr. Chairman. It's a real pleasure to be here. Mr. Pallone, other members of the subcommittee, thank you for the opportunity to testify before you today. The most serious threat to the nation's long-term prosperity is the rapid and unfinanced growth of entitlement spending. Left unchecked, spending commitments for these programs will push federal deficits and debt to levels that many economists fear will precipitate a crisis. Experience shows that the consequences of such a crisis would be especially disastrous for the most vulnerable segments of our society, including those who are dependent on the programs for their financial security and health needs. The three largest programs are Social Security, Medicare, and Medicaid. In 1973, spending on these programs was 4.8% of GDP. 4 decades later, that number had jumped to 10% of GDP, a 5.2 percentage point jump, which is larger than today's spending on national defense. In its latest projections, CBO shows the combined spending on Medicare and Medicaid, the health entitlements, growing from about $0.8 trillion in 2012 to $1.8 trillion in 2023. That's a $1 trillion jump in spending and represents 55% of all the new resources available in 2023 compared to 2012. Looking out into the future, the problem is even more daunting. Both CBO and the actuaries who produced the Medicare numbers for the annual trustees report expect healthcare cost inflation, along with the surge in enrollment, to push federal entitlement spending up very rapidly in the decades ahead. CBO estimates that the combined spending on Medicare, Medicaid, and the health law's new premium subsidy program will rise from 5.4% of GDP today to 8.4% in 2030. And these projections assume very deep cuts in what Medicare pays for these services for seniors, assumption that is highly questionable. Under an alternative scenario that CBO produces, the number could rise to as high as 12.4% of GDP just on the health entitlements by 2050. The consequences of various approaches to the problem vary quite a bit. Our budget situation would be far worse if not for large offsetting budgetary cost reductions that have already occurred. In the 1980s, average defense spending was 5.8% of GDP. In the last decade, it was 3.8% of GDP, even with the overseas engagements of that decade. All of that savings and more has gone to finance higher entitlement expenses. There's much concern today about the effects of the sequester. It's quite plain that the reason the blunt instrument of the sequester was enacted in 2011 is due in large part to the unaddressed problem of rising entitlement costs. The cuts are going to have to come from somewhere, and if there is no consensus on entitlements, then the cuts will inevitably fall on discretionary accounts, including education, job training, and public health funding. One of the approaches to the problem would be to use the provisions of the 2010 healthcare law. There's been much talk about bending the cost curve through those provisions. But it's really important to note that CBO estimated essentially no savings from those provisions when they estimated the bill, and there's been no evidence since then that they will produce any savings. Instead, the 2010 law used the same formula that's been used in the past to hit budget targets, which is large, across-the-board, and indiscriminate cuts in the Medicare program. In particular, the law included an annual productivity factor adjustment that will reduce payments to institutions on an ongoing basis starting this year. According to the 2012 trustees report, the cuts will push revenue down so much that about 15% of all hospitals will be operating in the red by the end of the decade. That number will jump to 25% in 2030 and 40% by 2050. Actuaries have made it very clear they don't expect this to happen, and so they produce an alternative set of assumptions for the Medicare program, assuming that they'll be reversed or partially reversed. When they do that, projections for Medicare are essentially unchanged from prior to the law was enacted. Another approach to solving the problem was tax. The Congressional Budget Office did a study for Chairman Ryan last year on if you solve this problem entirely on the tax side of the equation, what would it take essentially? They estimated that to close the gap between the current policy and then what would happen with the alternative projections would take about a 33% tax increase across the board on income taxes and corporate tax rates. Very, very large tax increase. Let me conclude by saying that the most significant risk of all this is for the social safety net, because in the midst of a federal debt crisis, abrupt changes in policies would be required to continue borrowing at preferential rates in the global market. That has happened to other countries, and it's not out of the question that it could happen here. Thank you very much.
Chair thanks the gentleman, and now recognizes Mr. Archambault for 5 minutes for your opening statement.
Thank you, Chairman Pitts. Thank you, Chairman Pitts and Ranking Member Pallone, members of the committee. Thank you for this opportunity to bring a local perspective to this important issue of protecting our most vulnerable citizens from the entitlement crisis. My name is Josh Archambault, and I serve as the Director of Healthcare Policy at a nonpartisan think tank, Pioneer Institute in Massachusetts. This morning, this afternoon, I'd like to focus on Medicaid, a program, especially in states with historically generous eligibility, such as Massachusetts, that may foreshadow some of the underlying issues that are sure to be exacerbated under the Affordable Care Act. Medicaid outcomes that deserve a closer look include the tremendous budget pressure in states and the crowding out of billions of dollars of spending on other public priorities, the reaction of state leaders to cut access to benefits and hike taxes to fund the program, and the increasing inability of patients to access providers, which may lead to worse health outcomes. In my opinion, as long as the program remains in place in its current form, these problems will persist and we will fail to protect the most vulnerable. Lawmakers in all states, red or blue, have been prevented from investing in our kids and our communities due to the ballooning costs of Medicaid. For example, in 2012, 35 states funded elementary and high schools at a lower level than in 2008. This translated into fewer teachers in the classroom and less police officers on the street. Sadly, these trade-offs fall disproportionately hard on vulnerable communities. Even with the federal government offering to pay a significant portion of the ACA's Medicaid expansion costs, any additional spending does not come free. The federal portion of the additional $638 billion will have to come either from higher taxes, from our sluggish economy, or from cuts in the budget. While supporters argue that the state portion of the additional spending will be minimal, roughly $33 billion, it cannot be denied that many states are struggling to pay for their current program. As a result, state leaders have cut access to benefits and hiked taxes to fund the program. In 2010, 15 states cut benefits in Medicaid. In 2011, 18 states did. Putting aside the debate over the generosity of Medicaid programs in each state for just one moment, we know the pain of these cost containment strategies are felt most strongly by the beneficiaries themselves. Instead of being able to vote with their feet and take their business elsewhere, they are stuck with these top-down decisions that dictate their insurance coverage. And the outcome has been poor access to providers and worse care outcomes for those on Medicaid. The federal government has placed restrictions on how states can manage costs in the program. As a result, the prime tool to save money is to decrease payment rates to providers. States that have already expanded Medicaid eligibility tend to pay for it by cutting reimbursement rates to finance the expansion. Over time, this has resulted in underpayment of doctors and hospitals and more providers refusing to treat those on Medicaid. This trend prevents many recipients from gaining even basic access to specialists. As a result, when Medicaid patients are admitted into a hospital, they are often sicker. Lower rates also may account for more ER visits by Medicaid patients. This form of care is both uncoordinated and expensive. In 2010, at least two-thirds of states cut provider reimbursement rates. In 2011, 39 states did. And in 2012, almost all 50 states cut rates. The administration encouraged further. As a result, access issues are likely to get worse, making it harder for even the most vulnerable on Medicaid to find a physician to see them. In 2011, a GAO study documented that children on Medicaid often have worse access to physicians than those with no insurance coverage at all. For many years, as Massachusetts has provided coverage to a much higher income level than in most other states, access remains a problem. Even the Commonwealth, with the highest per capita doctor ratio in the nation, still has a problem with access. A simple anecdote illustrates this problem well. A Boston area Medicaid recipient was provided a list of eligible providers by the Medicaid office, and yet failed to find one accepting new patients after calling over 20 doctors. Policymakers should be concerned about the string of troubling outcomes that are appearing more often in the academic literature, and these studies raise legitimate questions about the quality of care being provided. If Medicaid outcomes were presented as part of a business, it's my opinion it would be shut down because it's not serving its consumers well and in some cases may be hurting their health. Reform requires a departure from the current mindset that having access to a Medicaid card is the same as having access to a doctor. Thank you so much for your time.
Chair thanks the gentleman and now recognizes Dr. Fader for 5 minutes to summarize your opening statement.
Thank you, Chairman Pitts and Ranking Member Pallone and members of the committee. I'm pleased to be with you today to speak on the future of Medicare and Medicaid. Continuing to slow growth in these invaluable programs is essential to meeting the needs of an aging population. But these programs are neither doomed nor in crisis. Briefly summarizing my written testimony, let me explain why. First, per-person costs in Medicare and Medicaid have consistently grown more slowly than private insurance premiums, despite these programs' focus on older and disabled people with the greatest health care needs. In fact, in the past 3 years, Medicare's per-beneficiary costs have grown so slowly, practically zero last year, that CBO has reduced its Medicare spending projections for the next decade by more than $500 billion, on top of the $500 billion plus in savings from measures taken in the Affordable Care Act. CBO has also reduced its Medicaid projections for that period, excluding ACA coverage expansions, by more than $200 billion. Second, what that means is that it is not growth in spending per beneficiary, but growth in the number of beneficiaries that has become the primary driver of increased Medicare and Medicaid spending. It is this growth in the elderly population, as we baby boomers turn age 65, that requires us to actively promote the payment and delivery reforms initiated by the Affordable Care Act to make our health care system more efficient. There is no status quo in our healthcare system or in our public programs, Mr. Chairman. All our programs are in a state of active change aiming to improve efficiency. Third, as these innovations develop, and they will take time to develop, there are additional measures we can take, not in Medicaid, given already constrained provider payment rates and existing opportunities for state flexibility. Proposals that would secure more than modest savings, like block grants or per capita caps, would shift costs to states and reduce access to care. But on Medicare, as part of a balanced deficit reduction package, we can refine existing payment mechanisms at the same time we promote their reform. My testimony includes a few examples of refinements that reduce unnecessary overpayments and promote efficiency. These measures and others are not, as critics claim, arbitrary or unjustified cuts that endanger access or quality. On the contrary, as MedPAC emphasizes, they actually enhance provider efficiency. And if too great a gap emerges between public and private payments, the solution is not to have Medicare pay more. It's to promote cost containment across the whole healthcare system through collaboration among public and private payers in payment design and payment constraints. Fourth, only so much can be expected of reducing Medicare costs per beneficiary. A balanced deficit reduction package must therefore include new revenues to serve an aging population. As the elderly population doubles over the coming decades, it is no less necessary for the federal government to invest in health care than it was for state and local governments to invest in education, as they did when the very same people began entering public school 60 years ago. An alternative course of action, changing entitlement structures through vouchers or block grants, or adopting an overly ambitious savings target that could produce the same results, would fail to serve the growing elderly population, undermining some of the most vulnerable members of our society while shifting costs and actually increasing health care costs. Such measures might save federal dollars, but keep in mind that half of Medicare beneficiaries have family incomes of less than $25,000, and they already spend 15% of their budgets on health care. Such action cannot be justified on grounds of fiscal responsibility. Stabilizing the debt in the coming decade at 73% of the economy would require another $1.5 trillion in deficit reduction and would give policymakers time to identify the further steps necessary to reduce costs throughout the health care system in coming years. And it will enable us to meet our responsibilities to an aging population rather than abdicate those responsibilities by radically restructuring Medicare through premium support vouchers or by restructuring or severely cutting Medicaid or other programs that protect low-income Americans. Thank you.
Chair, thanks to the gentlelady. That concludes the opening statements. I'll begin questioning and recognize myself for 5 minutes for that purpose. Mr. Capretta, I've read over your testimony, and I must say I'm very concerned for our most vulnerable citizens if we don't fix these problems. Do you believe we have a health care access and coverage crisis on our hands if these valuable programs for our most vulnerable citizens are not strengthened?
I do think that the problems in Medicaid are becoming worse. The sort of acute care side of Medicaid, from providing access to primary care, emergency care, specialist care. And every study that I've looked at says that that will exacerbate the problem quite substantially because the supply of physicians willing to take care of those patients is fairly constrained. It's not likely to go up rapidly, even from the training of new physicians in the coming years. And so, yes, I have a real concern that you see in some parts of the country, California, for instance, emergency rooms are crowded very heavily with people that are on the Medicaid program. That problem will become worse in 2014 and 15.
You discuss in your testimony the unsustainable Medicare cuts in Obamacare, with more than 14 million Americans depending on the Medicare Advantage program today. What do you think the Obamacare cuts and the even more recent proposed Obama administration changes mean for the beneficiaries enrolled?
Well, the estimates are that the combined effect of the regulatory changes they're proposing, along with the statutory cuts, are that Medicare payments are going to go down by 7 to 8% in 2014 compared to 2013. So what we've had here is a temporary period where the administration really tried to artificially pump up Medicare Advantage, frankly, and put a new bonus program in that was really outside the normal process of demonstrations, pumped a lot of money into the program, sort of unfounded in my opinion, and then now they've taken that away and they're going to cut back on the payments quite a bit post some of the activity last year, and I think the effect is going to be very predictable. There's going to be plan withdrawals, there are going to be a lot of Medicare Advantage people pushed out of their program. The actuaries assume the number of enrollees will go down by a few million in the next few years.
Now, Dr. Archambault, you note the added cost to states associated with the Medicaid expansion. Many states, including my home state of Pennsylvania, have not agreed to an overexpansion of the Medicaid program, which could cost the state approximately $5 billion over 10 years. Yet others are trying to sell the enhanced federal match to states as free money and criticize governors for rejecting the expansion. From your perspective, is the expansion not a risky investment for states, one that could cost them in the long run?
Yes, certainly his opinion. I talk to state legislators, something like, we face X short pay, this is unaffordable, and is even more unaffordable. So I certainly think from both a state budget perspective, it is going to put some real strain on their budgets going forward if you enroll additional folks. And as I highlighted in my testimony, certainly federal dollars are not free. The taxpayers that are constituents that pay both state and local and federal taxes will feel that pinch in the future.
Now, from your experience and review of the Medicaid programs undergoing past expansions, you note in your testimony that the vulnerable suffer. Today, the released staff report outlining major reasons for Medicaid reform, which shows the program is already struggling to serve the most vulnerable. What will a dramatic expansion of the Medicaid program mean for the program's current citizens who already struggle to access services, like the disabled, who often have long waiting lists for home or community-based care initiatives, when resources will have to be diverted to cover the growing cost of an expansion rather than to serving them?
You know, I think you highlight a very important point going forward, that as you add more millions of additional people into a already strained and broken system, it's the folks that have the most difficult health needs, that maybe already struggle to find a primary care doctor or a specialist, are going to be even more disadvantaged in getting access to those people because there will be so many more people in front of them in line. We have multiple examples around the country. I know that the Committee on Oversight and Government Reform released a bipartisan report highlighting the billions of dollars in fraud and waste that we've seen in the New York Medicaid program for disabled folks, and I think it just highlights some of those issues that already exist in this program and need to be addressed with real meaningful reform going forward.
My time has expired. The Chair recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask my questions of Dr. Fetter. A number of recent reports, including the National Health Expenditure Report and projections from the Congressional Budget Office, have highlighted the slowing in Medicare cost growth. And the Affordable Care Act has a number of provisions designed to both reform health care delivery and improve the quality and efficiency of health care. A GAO report a couple weeks ago raised concerns about the long-term sustainability of some of the reforms. Estimates based on the GAO report project that if the reforms are sustained, it could result in as much as $13 trillion in deficit reduction over the next 75 years. So I just wanted to ask if you could assess what impact the ACA is having on Medicare cost growth and the sustainability of the delivery system reforms designed to improve quality and efficiency. Can you help us get our hands around the sustainability issue? And then last, we rely on a lot of economic models to project costs out into the future. How reasonable are these 75-year projections that are made by GAO and others?
First of all, Mr. Pallone, the GAO report that you're referring to and the estimate of unsustainability was a gross misrepresentation of what can be called a projection. Those large numbers of unsustainability were based on assumptions that came from the requester, Senator Sessions, that ignored both the cost savings that are in the Affordable Care Act and the revenues associated with the Affordable Care Act. If you ignore both of those, it's not surprising that you come up with a problem. The GAO report, like the CBO estimate after CBO estimate, shows that as the law is written, that the expansions are indeed sustainable, and in coming decade, in this decade, they actually modestly reduced the deficit. In the subsequent decade, they significantly reduced the deficit. Now, the actions that in the Affordable Care Act that control costs include measures that CBO does score, which, as shown in these estimates, which are elimination of overpayments to providers and to MA plans that have been recognized by experts for some time as excess and overpayment. But in addition, the Affordable Care Act has put in motion innovation in health care delivery to move not only the Medicare program and the Medicaid program, but also the entire health care system away from a system that rewards more and more and more expensive services and instead rewards providers for efficiently delivering quality care through better coordination, better involvement of consumers in their own care, and avoidance and reduction of hospital use. Those innovations are just getting underway, but those mechanisms have considerable potential for improving the efficiency not just of the public programs, but of the healthcare system overall.
Thank you. Let me ask you, you got into a little, you testimony, you said that 3 years is dramatic rate of increase in Medicare beneficiary. At the same time, aging demographic population projected to increase the number of Medicare beneficiaries from 50 million today to almost 90 million by 2040. So even if per capita beneficiary costs remain stable relative to the increased number of beneficiaries will drive cost growth. Just talk a little more about the relative contribution of excess cost growth or spending per beneficiary and increasing enrollment as drivers of Medicare cost growth. And is it reasonable to think that controlling costs alone without considering revenue which I mentioned in my opening statement, is a realistic approach to funding Medicare.
Yeah, I think given the slowdown in Medicare cost growth, that the amount of what's called excess cost growth, which is above inflation, has diminished substantially in terms of projecting the future cost projections of per capita costs or of total costs. What's happening is that the costs are being driven by the aging of the baby boom generation. As several of you referred to in your testimony, this is not something that is a surprise. The baby boomers have been coming. I'm at the front of them and proud to be one for a long time. It is the numbers of people on Medicare who are now driving the overall cost growth.
Well, then what about the revenue aspect?
I'm glad you went right there. The revenues become critical in that respect. And I mentioned in my testimony that the state and local governments increased their spending on schools when we baby boomers entered school by about the same percentage as we're now looking to increase costs in Medicare. And that investment is essential. We simply don't abandon the baby boom generation who are working hard and contributing. We need to support the care that baby boomers will need through enhanced revenues at the very same time that we are continually improving the efficiency of the program and getting values for the dollar.
Thank you.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the committee, Dr. Burgess, 5 minutes for questions.
I thank the Chairman for the recognition. Mr. Archambault, let me ask you a practical question. And I realize we're in a congressional hearing, so practical question isn't really fair game, but I'm going to ask it anyway. If you have, assuming a state that's going to do the Medicaid expansion under the Affordable Care Act, and you have a young person who's 20 years of age, well, let's say 27 years of age, who is at 135% of the federal poverty level, their care is going to be matched, the cost of their care is going to be paid for by the federal government, 100% match. Is that correct?
Well, we assume in that state that's doing the expansion, they also have a state-based exchange that's open.
Well, they'll be below the statutory rate. I mean, there's statutory language in the Affordable Care Act that says if you're below 138% of the federal poverty level, you have to go into the Medicaid. Now, I don't know how the Supreme Court decision actually changed that. I guess what I'm getting at is if that same person who's 28 years of age, covered at 100% match, actually gets pregnant during the course of that coverage year, then are they bumped back down to the 54% or 57% match? Do they drift in and out of that? Well, who keeps track of that?
I think you're right, Representative. I think you raise a very good question about some of the churn concerns that we have in and out of the Medicaid program. Who has responsibility at the state level versus the federal level on all of these eligibility determinations? Well,
in fact, we learned during all of the difficulties with the Deepwater Horizon, and not this subcommittee, but another subcommittee of the full committee had a field hearing down in Louisiana, and I was somewhat startled by the variance in earnings that people can have, and that someone might earn their entire yearly income of $50,000, $60,000 in May and June if they happen to be a shrimper in the Gulf Coast of off Louisiana. So how do you deal, who's going to be responsible for putting that person on Medicare when times are tough and in the exchange, and then figuring out what sort of subsidy they get in the exchange when the shrimp are coming in?
Yeah, I think there's a huge technology lift that's being required and expected of states and the federal government to be able to tell whether somebody is here legally, how much money they make, whether they qualify for subsidies or not, and we're very concerned about that ability going forward.
Well, and it's not just an esoteric or academic question, because there was someone from HHS who's in charge of the technology piece addressing AHIP this past week, and seemed to, in the report in the CQ Health Beat that I read, was significantly concerned about their ability to produce what they are supposed to be able to produce by October 1st, because October 1st people are supposed to go live and go online and sign up for this. Is that correct?
Yes, that's correct.
Well, let me just also say that I saw what testimony was privileged in the Supreme Court on the second day of the oral arguments last year. Didn't turn out the way I thought it was going to, but I was very concerned when I heard the Solicitor General say that people showing up in the emergency room without insurance are what are driving the costs up for the rest of us. And actually, your testimony referencing the Millman study about the cost shifting due to low Medicaid reimbursement rates is really the cost driver that we ought to be concerned about. And in fact, it's hard for me to understand how we are fixing that underlying problem of cost shifting by expanding the program that's causing the problem in the first place. Maybe you can enlighten me as to how that's going to work.
Representative, I think, you
It's fair to say it ain't.
Yeah, it ain't. And I think you have an even broader question, which is the cost shift onto small business in particular when you under-reimburse for Medicaid.
Well, thank you, and I really appreciate everyone being here today. Mr. Capretta, let me just ask you, you heard part of my opening statement, concerned about the fact that the dual eligible, we talk about a dual eligible population as if it is a monolithic group, but they're not, and we all know that there are subgroups within that group that cost a great deal more than some of their other counterparts. How really, as a health policy person, how do you go about trying to get your arms around the scope of that problem and so that it makes sense? I mean, you have people that may cost an average of $59,000 a year for their care if they've got 5 chronic conditions, and people who may cost a fifth of that. How do you reconcile all of those differences within that group?
Well, the heart of the problem is that many of those beneficiaries are in unmanaged fee-for-service Medicare. With the federal government put them in, or they defaulted into a unmanaged system and were in it for a long time, their health deteriorates, they're in an unmanaged system, no one's really watching over the full spectrum of care, and then they end up in a situation where they need a lot of intensive intervention with Medicaid as well as Medicare, and their 2 programs are not coordinated. So I think, frankly, the heart of the problem is that Medicare has too many beneficiaries in an unmanaged system, and they end up falling through the cracks.
Thank you, Mr. Chairman. I'll yield back.
Chair thanks the gentleman and now recognizes the gentlelady from Virgin Islands, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman. And, you know, I just needed to point out that the Affordable Care Act did increase the reimbursement rates for Medicaid as well as made other improvements to that and Medicare. Dr. Fetter, while making up only 25% of the Medicaid population, the elderly and people with disabilities account for 2/3 of Medicaid spending. Many consumers and advocates are concerned about the loss of essential services, especially to these 2 vulnerable groups, in the name of reducing the debt and balancing the budget. I'm especially concerned about how proposals that would cap federal Medicaid funding would affect these populations. As you heard in my opening statement, we have firsthand experience in the territories with capped federal funding for Medicaid. It hasn't made it more efficient. They haven't made people better off. It's just shifted the burden onto the territories, the localities, and the families, and I'm sure the same would happen here. So that's, can you tell me what the implications are for low-income families, senior citizens, and persons with disabilities if the federal government were to cap or otherwise limit Medicaid funding, particularly for the frail seniors and disabled individuals who are likely to need long-term care services?
Dr. Christensen, you rightly recognize from your experience that a large part of the Medicaid program does go toward long-term care as well as health care for people with disabilities. And any effort to cap that program so that it doesn't grow with the demand for care and with the cost of care the burden will fall on, or will place a burden on beneficiaries. We know that the people who are receiving long-term care from Medicaid pretty much throughout the nation they're not receiving excessive care. They get pretty much less care than they need. In many states, they would like to move more aggressively to provide home and community-based care, but that, unfortunately, that does not necessarily reduce costs. It may increase them, and the states will be, I believe, in the future, sorely pressed to keep up with the growth in the elderly population and the demands it places. To simply put a lid on the program spending, on the federal contributions, is to leave the states holding the bag for this growing elderly and disabled population, unable to serve them, and forced to make significant choices as to who would get services and who would not. It's not about flexibility. The states have flexibility. It's about who's going to get served, and somebody's going to be in serious trouble.
Right, and you've already answered the question about shifting the cost, because it's not going to control costs. It's just going to shift the beneficiaries in the states.
That's completely correct.
Yeah. Can you talk about how better care coordination and other delivery reforms can improve care in Medicaid? And you've already said, Can you answer that for me?
Sure. The whole idea is to move away, as Jim was referring to, from a system that does not enable people or providers to work together to coordinate and integrate people's care. And so we have in the Affordable Care Act a number of measures to achieve that goal, the coordination, whether it is the accountable care organizations or the medical homes or the health homes in Medicaid, a host that start rewarding providers for working together to coordinate care.
And another question. As a physician, I was really surprised by some of the assertions in Mr. Archambault's written testimony regarding Medicaid and the health outcomes of people who are covered by Medicaid. For example, he suggests that Medicaid may be harmful rather than supportive of improved health. And I know you're familiar with the Oregon Health Study and others that show better self-reported physical and mental health in Medicaid recipients compared to those who are uninsured. And he cited the GAO study, and his testimony says that it documented that children on Medicaid have worse access to physicians than those with no insurance at all. But the GAO study actually shows that 78% of physicians nationally were participating in Medicaid. So we understand that there are challenges to Medicaid and as in all insurance, but I'd like to ask you to comment on those studies and what the evidence shows about the impact of Medicaid on access and outcomes.
Yeah, I too was surprised, Dr. Christensen, and you said Medicaid is improving access by, in the Affordable Care Act, increasing the payments to primary care physicians. But the research literature quite consistently shows that Medicaid beneficiaries look very different from the uninsured and look quite like the insured, the privately insured population in terms of their having a medical home, a doctor whom they see, in terms of their visits, and in terms of their health status. So Medicaid is enormously valuable. We've seen this recently in what was a natural experiment in Oregon, where,
yes.
and which was not contaminated by what we sometimes can't tell the difference whether they're sicker or the populations look the same, which absolutely I think astounded its own authors as to what a difference that Medicaid made to people's health outcomes and health services use.
Thank you.
Chair, thanks, the gentlelady. Now recognize the gentleman from Texas, Mr. Hall. 5 minutes for questions.
Thank you, Mr. Chairman, and I do thank you for this hearing. It's certainly helpful because it's going to give opportunity for us members to understand the financial challenges and everything facing our nation, and also hear from experts as why doing nothing to improve it's not the answer we're listening for. And I'd say this is one thrust that members on both sides are very interested in, Republicans, Democrats, whatever. This is a major problem, and I think the chairman started out with this question to Mr. Capretta and to Mr. Archambault, and I think your answer was that you do believe that seniors and our most vulnerable citizens are facing an access to care crisis. That's a gimme, isn't it?
Directing that to me, I did answer in the affirmative. Yeah, I do think there's some serious access problems, particularly in the Medicaid program.
And do you feel that Washington's ignoring this crisis?
The Affordable Care Act, the health care law, tried to address it with a temporary federal matching rate increase, but it's a 2-year program, and the nature of the problem is much, much larger than what they put on it, so I don't think it's been addressed adequately.
Well, do you think it's, I guess I was in the Texas Senate from 1962 to 1972, and congressmen came down to Austin, Texas to tell us they had 2 wonderful new programs, and that one, if we weren't careful, one could cost around $200 million a year. And the other, Medicaid, if we weren't just quite careful and really watching it, it could cost maybe almost half that much. I regret to say that in 45 years, Medicaid went from 0 to $400 billion a year. Now $600 billion a year. Though that's all part.
That's correct. Yes.
How fair do you think that really is to youngsters that are 20, 21, 25, or 30. I can't imagine anybody being that young, but how really fair is it to ask them to be paying into a program that we can't honestly guarantee it's going to be around the day it is in any way like it is today when they become eligible for the program? What do you say to those youngsters?
That's a very good point and an excellent question. I think you're probably in a difficult position with them because they are facing large, if the programs are left unreformed, they'll end up paying probably 3 times. One's for the current generation, one's for their parents' generation, and one's for their own generation. And that's really not what was intended. Especially in the Medicare context, the idea was it was a contributory program where across generations you roughly paid the same, and then you've got a earned benefit in retirement for your health needs. The way it's shaping up is there's a big push to continually raise the tax rate financing the program so that future generations of retirees are going to pay way, way, way more than previous generations.
The Medicare trustees in their 2012 report lay out 2 dates for insolvency. The first and most likely reported suggests that Medicare Trust Fund will be bankrupt in 2024. And the second, and some suggest that the more realistic of the two, puts the date of insolvency at 2017, just 4 short years away. What number should we believe?
I hate to dodge the question, but probably both, because they really tell you 2 different things. The first is the 2024 date tells you when there's simply no more reserves in the trust fund, so any claims that come into the Medicare program at that time will probably, the law's a little unclear, probably be paid at basically 75 cents on the dollar. So that's essentially what would happen after 2024 if the trust fund's allowed to go totally to zero. 2017 is when the trust fund is running a cash deficit. So essentially that means the federal government's going to have to borrow even more money out in the outside world to cover Medicare's expenses. That's kind of the time when you should start worrying about the overall finances of the federal government.
I think, I yield back.
Chair thanks the gentleman. Now recognize the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes for questions.
Everyone here agrees that we have a growing, aging population. We know that. And I appreciate my colleague from Texas saying, let's talk about practicalities. But are we really, as a Congress, not just as Democrats or Republicans, talking about how to practically address these problems without causing more pain for the elderly in America, whose people over 65 making a median income of $22,000 a year, a Social Security benefit averaging $15,000 a year, out of which, let's remember, that's where the Medicare premiums come from. So you can't even talk about these programs separately. Are you kidding me that we're going to tomorrow see the passage of a budget that not only repeals Obamacare, meaning a number of the improvements to the total health care system, some of the things that account for the reduction in spending on Medicare, and that turns it into a voucher program that cuts Medicaid by turning it into a block grant by $810 billion over 10 years. Can't we do better than that? I mean, this whole conversation just drives me crazy. Old people are going to, they're going to grow in numbers. Poor people are going to continue to grow in numbers if we do those things. So why don't we sit down and figure out those practicalities? My colleague raised some issues that I think do need to be dealt with. We can do this. I wanted to ask Dr. Fetter a couple of questions about payment. In terms of Medicaid, the Republican would block Medicaid, as I said. Can you explain how blocking Medicaid would severely restrict Medicaid's ability to protect those that fall on hard times, such as the economic downturn that we're still living through.
Well, Ms. Schakowsky, it's exactly the opposite of the attention or the serious consideration you want to get to meeting the needs of a growing elderly population would be to slam a lid on the funds that states have to deal with not only elderly and disabled people, but other low-income people. There is not enough flexibility in life to enable states to deal more efficiently with this population, as is often claimed. States have flexibility to manage care in their programs. The only flexibility this would give them would be to essentially deny care to eligible people or cut rates even further. Well, you are, I think, right to point out that when people are insured, we have lots of evidence that shows that people get care earlier, they get better care, and they are less likely to die than people who don't have insurance. I can't tell you that that means that we will spend more money on, that we won't save anything, because unfortunately, letting people die without care can mean spending less money. But that is not the way this society ought to operate and take care of its own. I hear a lot of concerns about what are purported problems in the Affordable Care Act from comments today. But as I understand it, that many of these members are planning to repeal the very coverage that would prevent the people from being seen only at that last minute.
Well, let me just end with this. What I see in the plans that have been suggested on the Republican side is cost shifting. That we say the federal government can't afford it, but frankly, what the American people are concerned more about than the debt in this country is their own budgets, their own inability to get what they need. Why would we want to exacerbate those problems? Let's work together. I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate you all being here. It's an important debate and discussion we're having. And I like my friend from Texas, Mr. Hall's comments on just solvency of these programs, the 2017 date, the 2024 debate. You do that in discussions with Social Security, which is 2035, I think. And the way I try to explain it to my constituents, absent reform, and this is from a letter from the Social Security Administration. When you retire, you get a letter, about in the 5th paragraph says, if we do nothing, you're going to get, in essence, 75% of your promised benefits. Because there's a trust fund, as I understand it, and the money's going, as we pay money in, it pays out to beneficiaries, but when you trip these dates, then only what gets paid out is what's in that fund. So that's why Social Security will be, someone who's expecting a $1,000 Social Security check will end up getting, on that date, left unchanged, a $750 check. I see Mr. Capretta, you're shaking your head. Is that how you understand that whole system? Is that
that's right.
Explain. And you're saying that that's true for the Medicare fund on 2017 or 2024, depending upon how we calculate that date.
It would be true in 2024, yes. They'd only be able to pay out claims financing at the level of revenue coming in at that point. So if the revenue is only covering 75% of the total claims that are being filed by hospitals on behalf of patients, the law is ambiguous about how that'll be handled. It doesn't say exactly how to handle it. The presumption is you just pay a percentage of the total claim.
Because there's no provision for us right now under law to borrow money to keep the new change delta
When the trust fund's depleted to reserves, there's no ability under current law for it to run in the red.
So Medicare pays, in essence, 70% of private care costs. I mean, I don't know if you know that or not. That's what
A little bit more than that, but that's in rough terms, right?
So if these insolvency dates hit, then they're going to end up paying
70% of that. Yeah.
A huge.
Yeah.
So it could be 35% to the providers
Right.
who are providing care.
And recognize that the law has already cut the reimbursement rates quite a bit. That the main provisions saving money in the Medicare program that have been discussed today at the hearing are provisions that simply apply across-the-board reductions to every facility in the country that's providing services to Medicare patients. It didn't distinguish amongst any of them based on quality or anything else. It essentially applied an across-the-board cut to every provider.
Now, let me ask a question, because then you talk about revenue, right? Maybe a solution would be more revenue. But under the Obamacare, the health care law, we increased Medicare taxes by leveling the 3.8% tax on unearned income, did we not?
That's correct. For anyone above $200,000 a year in annual income, if you're an individual, or $250 for couples.
So this must help that fund, shouldn't it?
Well, it didn't go into the Medicare Trust Fund, though. This portion of that tax increase was dedicated to financing the rest of the bill.
So a 3.8 tax on unearned income on the Obamacare health care law did not go to help prop up these insolvency issues on Medicare.
Correct.
Well, that's unfortunate if there's a funding problem. We also talked a lot during the debate, even in the presidential campaign, and I had Secretary Sebelius right at the table you're at, who in essence agreed that they had double counted the depletion of Medicare dollars into two directions. They double counted. In essence, I said $500 billion, but now we know it's like $716 billion. How did we double count that, or we didn't? We voted against the law. How did those who supported the law? How did they double count? How did the administration double count hundreds of billions of dollars?
They cut the Medicare payment rates, as we discussed, by about $500 billion.
Arguing that they're saving Medicare.
They're taking basically $500 billion, reducing what Medicare is paying to providers. That $500 billion was used under what you call the pay-go scorecard that's used in Congress to make sure legislation is at least deficit neutral or a little better. They used that $500 billion to show a positive balance on the pay-go scorecard. So that's one scorecard. And then they deposited it in the second scorecard, the trust fund scorecard, to pay future Medicare claims. So they did spend the money twice.
Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Prater, the title of today's hearing is Saving Seniors and Our Most Vulnerable Citizens from an Entitlement Crisis. It seems that the term entitlement has come to mean different things to different people. Too often people think of entitlements through the narrow lens of the programs that provide the social safety net for our seniors and the most vulnerable in our society, without considering the fiscal impact of tax entitlements, tax deductions, exclusions, credits, and other tax preferences which disproportionately benefit well-to-do Americans. One could call those entitlements. Can you talk about entitlements, both those providing essential services to seniors and low-income Americans and those providing tax breaks to more affluent Americans, and the relative role of each in the context of protecting the most vulnerable in our society and addressing our long-term debt?
Yes, Mr. Waxman. I think that we should start with the recognition that an entitlement is a commitment on the part of the federal government to provide benefits to as many people who qualify for that benefit as come as appear in a given year without a constraint through the appropriations process. And when we apply that definition, the benefits that come through the tax code are the very same kinds of entitlements as benefits as those that come come through direct spending. And that's, I think, been recognized by the Congressional Budget Office and others for many years. That's why we call them tax expenditures. There are some tax expenditures that do benefit low-income people, like the Earned Income Tax Credit and like the tax credit. It's the refundable tax credits in the CARE Act. But the vast majority of tax expenditures for health care, for housing, for pensions are disproportionately, overwhelmingly benefiting the better off, because the higher your income, the more you benefit from not paying taxes on those dollars. It can be argued that that spending is crowding out that some of the spending that improved spending that we need for middle income and lower income
the argument
population.
we hear for spending on entitlements.
I beg your pardon? Yes.
That's exactly the argument we hear for spending on Medicare and Medicaid.
Is that's crowding out, and
Yeah.
you're quite right. And what I'm saying, and I think that I'm getting your point, is that by spending on the better off in tax entitlements, it is that is a very much a part of the crowd out. Now, I would also say that I don't know that I would eliminate all of those. I would not eliminate the health, the tax benefit, because we need the risk pooling that it provides. But for high-income people, we do not need to be providing so many benefits.
Well, some have argued that cutting only spending entitlements while shielding tax entitlements would have a highly regressive impact. Is that what you're saying?
It surely would.
Okay. My Republican colleagues have proposed keeping tax levels at about 18% of GDP. With what we know about the aging of our population and the increasing need for health coverage under Medicare and Medicaid, is it realistic to keep revenues at that level?
No. It simply is not. And when I hear a concern for state budgets, and when proposals are being made actually to shift more costs to states, whether it's health care or if we look at long-term care, which is borne primarily by the Medicaid program, and different rates of aging in different states, the notion that we would deal with these kinds of issues without raising additional revenues is really unconscionable.
I was troubled by some of the accusations in the testimony of Mr. Archambault, and I believe they deserve to be fact-checked. First, Mr. Archambault asserts that Medicaid is not serving its customers well and in some cases may be hurting their health. Dr. Fader, isn't it true that the Medicaid program is completely optional for states? States are not required to provide Medicaid, isn't that correct?
Yes, sir.
So if governors really believe that Medicaid was harming their residents' health, do you believe they would continue to fund the program?
Sound pretty peculiar to me.
Many governors, even Republican ones, have already opted to participate in the Medicaid expansion offered as a part of the Affordable Care Act because it's good for their states and good for their citizens. Moreover, there is empirical evidence showing that Medicaid improves health. Isn't that accurate?
Yes, sir.
In 2008, Oregon conducted a randomized control experiment on how expanded access to Medicaid affects health. The results are very encouraging. The group who received coverage under Medicaid had substantively and statistically higher utilization of preventive and primary care, lower out-of-pocket medical expenses, and lower medical debt, and better physical and mental health than the control group. Could you comment on the assertions in Mr. Archambault's testimony?
We had discussed that earlier, so I can do it briefly. I think that the evidence you presented is what the predominant evidence on the value of Medicaid in terms of improving people's health and enabling them to get care. There's no question about it.
Thank you. Thank you, Mr. Chairman.
Gentleman's time expired. Chair now recognizes the gentleman from New Jersey, Mr. Lance, for 5 minutes.
Thank you very much, Mr. Chairman, and good afternoon to the panel. To Dr. Feder, good afternoon. You gave us a figure, and I just didn't hear it. I gather Medicaid at the moment spends roughly $400 billion a year. Is that right?
I beg your pardon?
Medicaid is roughly $400 billion a year. And I was interested in your testimony regarding long-term care. What percentage is in long-term care?
Long-term care is about a third of total Medicaid spending. Spending on the elderly and disabled, and for the low-income disabled, Medicaid is providing not just long-term care but health care. The two populations together absorb about two-thirds of Medicaid spending.
And by long-term care, do we mean nursing home care by and large?
Well, not necessarily. We mean help with basic tasks of daily living, which can happen in nursing homes, but also happen at home and in community daycare centers and other places.
And obviously, with an aging population, the baby boomers, there are going to be more people who are going to need
That's correct.
long-term care. Have you analyzed models that might be different from the model that we utilize today in America? I would hope it would be less expensive, but perhaps it would not be less expensive. Care from one's residence as opposed to care in a nursing home?
There has been a movement over several years, it sounds as though you're quite familiar with, Mr. Lance, to move people, to treat people at home where they want to stay, or help people at home where they want to stay. And on a per-person basis, it is cheaper than putting them in a nursing home. But we need to better serve that population. They are underserved throughout the nation, and that requires additional investment.
That would impress me as an area where we might work together in a bipartisan capacity, as undoubtedly there are going to be more people needing long-term care given the aging population, and particularly regarding those who are baby boomers.
I think that would be a wonderful thing, Mr. Lance, and I would appreciate or would offer any assistance in that regard that I can.
Thank you. Regarding tax expenditures, and I understand that this is a newer debate in America, but it's a debate currently occurring in our country. To you, Dr. Federer, or to other distinguished members of the panel, what is the largest tax expenditure at the moment in the country?
I think the largest tax expenditure is the exclusion of of employer-paid premiums from taxable income.
Other members of the panel, is that the largest tax expenditure in the country?
It is.
Yes, and I have stated in my campaigns for office that I do not favor taxation of that, and that has been welcomed by those who elect me to office. And I think it would be extremely difficult to tax those health care policies. Does the panel believe that it is at all realistic that the Congress, whatever its configuration, would actually do that?
Well, if I'm following up on Congressman Waxman's questions, I think that what's important to recognize is that if the Congress is proposing to put a lid on spending for Medicare or Medicaid programs, that to ignore the expenditures that disproportionately go to higher income people.
I understand that point.
And I think that's the context in which it's made. The other proposals.
So do you favor taxation, Dr. Federer, of a portion?
The proposals that I have seen that makes sense to me, and we actually are doing something very much like that in the Affordable Care Act. I think that the proposals that I've seen that make some kind of sense are the proposals that would limit the tax breaks for higher income people, but I would not favor taxing all those benefits.
You would not favor taxing all of those benefits? Yes.
It's important to recognize that the health care law did, in a sense, impose a tax on those benefits on high-cost plans.
Yes.
And it was not based on income. It was across the board.
It was across the board. Thank you. In your testimony, Dr. Federer, you do say stabilizing the debt in the coming decade would give policymakers time to identify the further steps that will be needed to slow the growth of health care costs throughout the U.S. health care system without impairing the quality of care. I believe I agree with that statement. At what level do you think it would be best, given the current situation, to stabilize the debt?
Well, in my testimony, I cited the work that's been done at the Center on Budget and Policy Priorities, advocating that we stabilize that percentage at 73% of GDP.
And what is it at the moment? It's a little higher, isn't it?
I apologize. I don't want to misstate a figure, so I will just provide that for you later.
Thank you very much. Thank you, Mr. Chairman.
Gentleman's time expired. Chair recognizes the gentleman from Georgia, Mr. Barrow, for 5 minutes.
I thank the chairman. Critics of the two warring tribes in Washington can find plenty to criticize on both sides. There'll be folks who criticize Democrats for having a blind faith in the future and sort of ignoring the long-term trends and problems here, having some faith in our ability to solve this problem down the road. Folks can criticize folks on the other side of the aisle for basically saying this is so ominous, so bad. We just got to get out of the business. We got to cost shift. We got to get out of the business of subsidizing the current model because it's just way too much for the taxpayer. Both sides, it seemed to me, that stereotype, seem to agree on something. They seem to accept the current level of spending and the current projections and the trends as being sort of the best of all possible worlds and sort of a given. And I challenge that assumption. I happen to think that this whole approach that most folks tend to agree on is, what are we going to do about how to pay for this? Sort of ignores the real challenge here, and that's what are we spending our health care dollars on? And what are the things we can do that would have a big impact on what we're spending on that would also alleviate the underlying problems that people are facing? I look at the scourge of Alzheimer's and the scourge of diabetes as being a whole lot more than the public tab associated with both of those diseases. Just to take two large, big-ticket items, for example. If we could crack the Alzheimer's code, for example, I think we'd have a big impact on Medicaid's viability and the burden that it's carrying all over the country. If we could crack the problem, the current trends of letting diabetes set up in the course of people's lives during their work life, and most of the big bills coming due only during Medicaid's time on the health care watch, we could have a big impact on Medicaid. But more importantly, we could alleviate the suffering of millions that really is not counted for in any of the discussion we've been having on this committee. So my question to you all is, if you want to attack the problem in terms of putting the technology out in front of the mandates, instead of figuring out how we're going to pay for business as usual, but what can we invest in that will make for business as unusual, that can actually affect what we're having to spend money on in a big way? And I'm not talking about nanny state stuff that has no practical chance of success. I'm talking about things we can hit if we make a good investment, a solid investment, a war on this or a war on that would have a big payoff, not just in terms of the public's share of the health care expense in this country, but also the suffering that people are experiencing in their lives. What are the two or three things that y'all say we ought to wage a war on to get at that would have a big impact on Medicare's budget, Medicaid's budget, and also the bottom line of what we're funding? Because I regard this whole approach as sort of taking the current state of affairs as a given. And I look at this in terms of we're missing the challenge of trying to find those breakthroughs, those things that would take a serious, concerted, coordinated effort of research and development and deployment to actually make a big impact, not only in people's lives, but also in terms of our nation's health care budget. What would you suggest we go after if that's the approach you want to take? I want to make the bad things we're paying for obsolete, not just be arguing about who's going to have to pay for them. I want to make the things that are driving our budget ox into the ditch and making people's lives miserable. I want to make those things obsolete rather than just figure out who's going to pay for them. Who would want to take a stab at helping us understand where we need to go in that direction?
Well, it's a big question. I'm sympathetic to your point of view, actually. I think it's a big challenge, though, to have the certainty that some kind of public intervention is going to have enough of a payback and certainty that you don't need to make other adjustments. So, in other words, my first point to you, I think...
recognize that if we solved a lot of problems that are killing people off at a certain age, we'd have a little bit more in terms of pension. There'd be a greater reliance on the pension benefits of folks who are living longer and healthier lives.
No, what I'm trying to say is that let's assume we made a big intervention in the areas you're talking about, and I'm about to mention one that I agree with you on. It's so uncertain that it'll have the payoff we both would like to see that you still have to make other adjustments in the entitlement programs because you can't bank on that having the 20-year effect that we're both looking for. But having said that, I do think that there are opportunities, especially in the area of diabetes, to make some progress. I think there are a lot of untreated and undertreated people with that condition that are heading into their Medicare years quite soon. And if we did a better job of coordinating care for that population, there is an opportunity, and I was part of a study that looked at this carefully, there is an opportunity to bring down some of that burden with some level of certainty associated with it. It won't solve our budget problems, though, I'm afraid to say, unfortunately, because there's some expenditures involved in providing better care for them, too.
Dr. Fetter, my time is running out. Have you got something you want to add?
I'm just going to add, I think that when Jim talks about investing in diabetes and in prevention and primary care, that's precisely what the changes, the payment and delivery reforms in the Affordable Care Act are aimed to promote. It is to enhance our focus on primary care and coordinate care at early stages when there are early difficulties in order to prevent the use of costly and services later on that actually could be prevented.
Just so you know, I'm not interested in something that's high maintenance, low impact. I want low maintenance and high impact. That's what I'm looking at. Thank you.
Gentlemen, time expired.
Mr. Chairman, I'm wondering if I could offer something to put in the record.
Has it been, have we looked at it yet? Do you know? Okay. Have we approved it? What do you?
This is a statement by Ron Pollock from Families USA.
Okay, without objection, we'll accept this submission.
Thank you.
Chair now recognizes the Vice Chairman of the full committee, Ms. Blackburn, for 5 minutes.
Thank you, Mr. Chairman. Just one comment I wanted to get in before I do have a couple of questions. Ms. Fader mentioned earlier that there was an increase in provider payments in Obamacare for Medicaid providers, and I just want to note that that is actually going to be a 2-year bump.
Correct.
And not a full-time, long-term payment. So basically what we're doing there is setting up another one of these cliffs. It will be a new SGR cliff because the money goes away after 2 years. And, you know, what we find out and what we hear from our governors, and one of the reasons so many of our state legislatures are having such heartburn over the Obamacare issues is because you put money in, then you take money out, and then what happens with those Medicaid beneficiaries, and where are they going? How are you going to pay for this? And quite frankly, I have to tell you that we all are compassionate and want to make certain that people have access to affordable care, but having the federal government put their hand further into that health care pot does not solve the problem. It makes it worse. It makes it worse. What we want to do, and what I've heard from my colleagues across the aisle even, you know, I'm happy to hear them talk about solving this problem and this access to care problem, because the more federal intervention you have, the worse the situation gets. The more limited is your access to care. And what we have found in Tennessee, and I'll make Mr. Pallone's day. He knows I can't sit here and not say TennCare. What we found through the, are you familiar with TennCare, Ms. Fader? And you know what a miserable failure it was, and how we had a Democrat governor that had to come remove 180,000 people from the rolls and restructure it. And one of the lessons learned is that having access to the queue is not the same thing as having access to the physician. And that is something that you see. I continue to ask everybody, show me a public option plan. Show me a federal mandate plan that gives you greater access, greater outcomes, and a lower cost. The truth is, Ms. Fader, there is not one on the face of the earth, not one, that has successfully done that. Mr. Capretta, I have a couple of questions for you. I sit in these hearings and I hear a lot about, you know, every time we look at something to save Medicare, to keep it solvent for a long period of time. Trustees have told us it's going broke. Every time we do that, we're accused of trying to drive grandma and grandpa off the cliff. And I find it so incredibly unfortunate, but I think that the real crime is to sit by and do nothing and say we're just going to be content with the status quo and not look at how we solve this problem. Tell me where you are with looking at these trustee reports. What are your thoughts?
Well, the latest CBO estimates actually are pretty interesting. They did lower Medicare's future expenditure rates going forward, but the largest reduction actually was in the drug benefit, believe it or not. You know, there's a lot of talk about Medicare and what it does and doesn't do and so on, but the drug benefit is essentially a competitive program driven entirely by private plans. It's been very competitive.
And it works?
And it works. The average annual growth rate, the average annual growth rate from 2007 to 2012 is a little bit more than 2% a year, well below the average for the rest of the program. And the largest downward adjustment CBO made in their estimates going forward was in the drug benefit, despite the fact that the health care law expanded the program by closing the donut hole. So there is a model out there of competition and private choice and consumer choice that's working. It's actually driven a lot of costs out of the program.
All right, I appreciate that. I want to talk with you also. Obesity. Mr. Barra mentioned Alzheimer's, which is a disease I am so familiar with because of my dad and my mother-in-law, both of whom have died with Alzheimer's, and I share his desire to crack that code. I think the other one is obesity. And you've had some interesting analysis on this. And what do you think, if we could reduce the obesity rates in seniors, what kind of impact would that have on the Medicare program?
It would have a very positive impact if we could do it. I think the challenge is the certainty of knowing which policy levers to pull that can deliver for sure on the outcome. I'm all for trying to address this problem in some way, to some degree. I think it will positively affect especially diabetes care in the program, where there's a big chunk of dollars associated with that. So we don't have a silver bullet, but I think some additional public attention for people that are aging into Medicare with that problem is worth your attention.
Thank you. Yield back.
Gentlelady's time's expired. Chair now recognize the gentleman from Virginia, Mr. Griffith, for 5 minutes.
Thank you, Mr. Chairman. According to the CBO, Medicaid will cost the federal government $5 trillion over the next 10 years, with as much as $638 billion of that directly linked to the expansion of Medicaid from PPACA. Recently, Governor McDonnell laid out the need for vast reform to make Virginia's Medicaid program more cost-effective before the Commonwealth can consider an expansion of those benefits and that program. The Governor has laid out 5 tenets for Medicaid reform. 1, service delivery through efficient market-based system, including more managed and coordinated care. 2, reducing financial burdens to the state by getting an assurance from the federal government that the expansion will not increase national debt. 3, maximize the waivers that currently exist to achieve administrative efficiencies through streamlining of payment and service delivery. 4, obtain buy-in from healthcare stakeholders in the state for statewide reform. And 5, achieve greater flexibility by changes to federal law, including more value-based purchasing, cost-sharing, mandatory engagement in wellness and preventive care, the development of high-quality provider networks, and flexibility around essential health benefits. Virginia Hospital and Healthcare Association has said that they will cooperate. The reforms that Virginia is now discussing are on a par or similar to what we have discussed here in the Energy and Commerce Committee, at least on our side of the aisle. And that flexibility with Medicaid programs, I think many states desire. So, Mr. Archambault, do you agree with Governor McDonnell that we need to have these Medicaid reforms and that not only Virginia but other states should be exploring these types of reforms and that we should be a partner with them? If you could explain.
Yes, Mr. Griffin, I think the governor has laid out and put his finger on a number of the issues that are exist in the current program. And this is a bipartisan issue. You have governors who have put in waiver requests that take over a year to get any response from the administration on whether they can move forward or not. So certainly I think both Republican and Democrats at the state level see the value of greater flexibility, and I think anything that Congress can do to grant that flexibility would be a move in the right direction.
And you say that there are Democrat governors as well as Republican governors who desire this flexibility?
That's true. I mean, we have one just south in Rhode Island in which they've been working on these issues for years, trying to get flexibility, and they got some additional flexibility to move forward.
And do you think that's because they sense that as the Founding Fathers did, that perhaps the individual states should experiment and find what works best, and then others can copy if they wish?
I think that's right. I mean, we even have an example in Connecticut with a Democratic governor in which they expanded recently in Medicaid, and they found that it was more expensive than they initially anticipated, asked for flexibility from the administration, and it was denied. So I think there certainly is a need and a recognition on both sides of the aisle at the state level of this issue.
Mr. Capretta and Mr. Archambault, both, what do you think that we can do to better serve the states as they try to figure out ways to be more efficient? I'll start with you, Mr. Capretta, since Mr. Archambault's had a couple of minutes.
I think this year is a historic opportunity to move ahead with some more Medicaid flexibility. Here you have an administration that would like the states to do a very large-scale expansion, which the Supreme Court said is entirely optional at this point. Many states are holding back thinking about it. I think they have a great deal of leverage, and you and the Congress have a great deal of leverage to say, before we do anything more to put more people into the program, let's come to a consensus about what the basic rules are for who's running what.
For those who may not follow Virginia politics closely, that's exactly what the Virginia General Assembly did, was they said, we're going to set up a special group to consider expansion that the President and the PAPACA encourages, but we're not going to expand until we've seen reforms that make it so that we can afford to do that expansion. And so you're recommending that perhaps we take that Virginia model and see if we can help encourage other states to do that by giving the flexibility.
I think there's a real pernicious effect. I worked in the administration, did a lot of Medicaid waivers in my previous job and in a previous administration. There's a little bit of an unusual and pernicious effect on one-off negotiations between an administration and a state. There ought to be rules that apply to every state that are fair to taxpayers across the country and not special deals given to some states over others.
All right, I appreciate that. I only have 6 seconds left. Mr. Archambault?
You know, I think a great example is welfare reform. That you had a lot of states figure out how to do it at the local level first, and then there were the same rules applied to all states.
And I've got to go, but I would be remiss if I didn't mention that Virginia led on that one as well. Thank you very much. Yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Kentucky, Mr. Guthrie, 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate being here. What I want to talk about, the health, we talked about 2024 is the date that Medicare goes insolvent. And that's if you believe a lot of the different accounting systems in the health care bill. I mean, the SGR goes away. Things like that happen to get to 2024. But let's assume we get to 2024 before Medicare goes insolvent. So if somebody is 66 in 2024, we don't know how the law is going to treat them. That's what the testimony has been here today. Will it be 75% of 70% payments to hospitals and doctors? And we just don't know that. I don't know if anybody would disagree with me on the panel that we don't know what will happen if Medicaid goes insolvent in 2024, which is what the President's health care bill that was voted on by the majority does. So if it goes insolvent in 2024 and we don't know how 66-year-olds going to be treated, we do know that if we pass the Ryan budget, someone who is 66 years old in 2024 will have Medicare as we know it today. And just think if I'm a baby boomer, I was born in 64 on the end of it. So if you're 65 today, if you're 65, as we speak today, you're on Medicare, do you hope to live to be 76? With our healthcare system, I think most people do hope to live 76. So what we're telling people today, we have no idea how you're going to have Medicare when you're 76 years old, unless we put a plan in place, which this side has put forth. A lot of people say, Washington, nobody ever tries to solve problems. We've known this is coming. Both parties have known this is coming for a long time. Baby boomers is the fact. It's a fact of life. But we do have a plan. If you're 65 years old today, when you're 76, you will have Medicare as you know it. And so what are we talking about doing the difference? Well, you know, people say, well, we need a balance of revenue. The President went around the country last year saying if we just asked the millionaires and billionaires to find at $250,000 or more to pay more, nobody's going to have to make any changes. Well, that's $80 billion. The President got $60 billion of the $80 billion in the fiscal cliff bill. I don't know if anybody in this room would say that's enough to solve the problem with Medicare, even if you got the additional $20 billion he promised. We even know the 3.8% Medicare tax on unearned income didn't go into the Medicare side. So asking the rich to pay more, the fiscal cliff bill, the $60 billion, didn't go to save off Medicare. It was spent essentially in the fiscal cliff bill. Most of it was spent on other projects. So when you say we just need to raise taxes to put it back into Medicare, I mean, we've seen what happened twice just recently. So what are we offering? I think, is Medicare Part D a good program? And people think Medicare Part D. He said it's the costs that people are saying Medicare costs per beneficiary have slowed, and a lot of it is due to Medicare Part D. So what we're saying is, okay, instead of, I think we had one panelist say, well, when baby boomers retire, they built schools when they had baby boomers, therefore they're just going to have to pay more for us to be retired. So I'm telling my children, my daughter is 19, she will be 40, in 30 years she'll be 49. 100% of all federal revenues is supposed to go to Social Security, Medicare, and Medicaid at that point. So I'm telling my daughter, when she's my age, she needs to wake up and go to work so my generation can be retired. That's what we're telling them. I mean, what else are they going to have? They're not going to have anything else. But what we are saying, if we adopt a program like Medicare Part D for the rest of Medicare, not only can somebody that's 65 years old today have Medicare till they pass away, as they know it and as it is, our children and grandchildren can have Medicare delivered to them in a way. Did the majority change Medicare Part D in the bill? They did change some benefit within Medicare Part D, but they certainly didn't change the way it's delivered. And so I don't know why it's so radical. If it was so bad to do the other parts of Medicare like Medicare Part D, then why wasn't it changed during the health care bill? It wasn't. And so what we can say today, we can say, children and grandchildren, my generation's retiring, you just owe it to us. Or we can say, children and grandchildren, we're going to promise to people who are near retirement because politicians promised them things that we had no idea how to pay for, but they organize their life around it. So we're going to honor it. That's what this budget's coming out tomorrow does. It honors the promise we made to people at or near retirement. But instead of asking our younger people to pay more, let's change the program in a way that we know works, because Medicare Part D works, and give them an opportunity to not to go to work every day to pay for my generation to be retired, go to work every day so hopefully somebody have grandkids, and they have grandkids, can have the America that our parents have given to us. And I think that's what our generation owes them. We don't owe them. They don't owe us. We owe them. That's what American Dream's been about. Now I yield back my time.
Chair thanks the gentleman. Now recognizes the gentleman from Louisiana, Dr. Cassidy, 5 minutes.
Hey, Mr. Capretta.
Hello, Doctor.
Que pasa?
Hey,
So as I gather, and I was looking up the CBO, Erskine Bowles, but if we do nothing, by 2035 or thereabouts, Medicare, Medicaid, Social Security, interest on the debt will consume 100% of federal tax revenue?
I think that's about right, yes.
Something like that.
Yeah.
I somehow wandered off where I should be. And I also believe, I know it's true, that current law says that we cannot, under current law, transfer dollars from the general fund to the Medicare Trust Fund. Medicare Trust Fund, by law, is supposed to be self-sufficient, correct?
The Medicare Hospital Insurance Trust Fund is in that circumstance, yes, that's
so
correct.
when A goes bankrupt, there is no more.
When it runs out of reserves, there's no, you have to change the law to put more money into it.
Dr. Fetter, is reform worse than bankruptcy? Because if we know, according to current law, that after, 2024, there is no money, that people will not have any dollars in Medicare Part A, is reform worse than
Mr. Cassidy, it's not quite accurate to say people will not have any dollars in Medicare Part A. As has been said, they would not, that Medicare Part A dollars would fall short of full expense.
No, that's when it's bankrupt, right?
Well, bankrupt, and there'll still be revenue coming in.
It'll
be pay as you go.
It's never, the short story there is.
Yeah, but it's going to be 10%, it's going to be 20%.
No, wait, we said it's 70%. And
no, it's 70% now.
The other percent, no, I don't think so. But the other part of the story is that we are not doing nothing now. I have heard it said several times today that if we do nothing, we are not doing nothing.
The accountable care organizations have never been shown to save money relative to
of course they haven't been shown to save money because they are brand new and we are piloting
No, they had
them.
demonstration projects which were deliberately selected to be places that had integrated health care.
I hear your concern about the previous pilots, and I think that, but there are design features, for example, in the Pioneer ACOs, who are sharing risk as well as sharing savings that have greater potential, in addition to which they are not the only demonstrations that are being
by the way,
pursued.
ACO, I'm sorry, I don't mean to interrupt, I just got so little time. ACOs account upon having a capitated or a per beneficiary payment, correct?
They are shared. They are paid toward there's a target on their spending,
So their
and
target
they
is
share savings or some of them.
So ultimately,
bear risk.
there is some sort of, an IPAP, for example, assumes a global budget for Medicare.
Well, that's a different question. If you want, an ACO is not the same as an IPAP.
So is a cap inherently wrong?
Well, let me just, there is not a cap in the ACO savings. There's a shared risk or ACO program. There is shared savings. What I think is wrong is to cap dollars and assume that we know how to deliver the services.
So New York State is
mechanism, and I also would say that an arbitrary cap that's significantly slower than the rate of increase in health care spending puts beneficiaries at risk.
So New York, Mayor Cuomo, Governor Cuomo, I'm told, is putting a global cap on Medicaid. Is that wrong?
I do not think programs should be globally capped.
So is there no limit to the exposure of the federal taxpayer to how much they can spend?
What I believe is that we need to adopt specific policy measures that do generate savings without putting beneficiaries or shifting risks to beneficiaries. It is shifting risk to beneficiaries that's acceptable.
Limited time. We know historically that New York, for example, has really gamed that system. So New York, which has half the population of California, has a program which is 25% more expensive. There are people in disabilities who are getting paid by New York Medicaid $5,000 a day.
I think the way to address problems in spending is to adopt specific policy measures to make the system more efficient.
Now, we know that Medicaid
some of which we know how to do.
We know that Medicaid is very difficult to reform. Mr. Archambault said that it takes a year, sometimes longer, to get a waiver. That doesn't really seem to be the flexibility or the agility.
I would say that Medicaid has a lot of that for moms a intensive plan. Some good is some is not. So there's been a reform aid program. Whatever.
But that wasn't the point. The point is that the flexibility that would give states the ability to sometimes shut this sort of thing down can take over a year.
What I've heard ignored in the previous comments is that what your budget is proposing is to take $800 billion out of the Medicaid
You're kind of
program.
dodging the point. My point being that there is no ability, or I'll put it this way, if it takes a year to 2 years or sometimes never to get the flexibility to address this, it shows that our ability to address it isn't quite agile.
I simply disagree.
Mr. Archambault, is it true it takes over sometimes a year or 2 years to get those waivers?
Yeah, I think there's multiple states. New Mexico is an example. Florida is an example in which it took at least a year, if not more. State of Oregon, Democratic governor, took a while to get permission for their waiver as well. Yeah.
So I'm almost out of time, but thank you very much.
You're welcome.
Chair, thanks, gentlemen, and recognize the gentlelady from North Carolina, Ms. Elmer, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel. I'd like to start off by saying, Dr. Fetter, you had made some comments, regarding the budget, and that, the budget basically repeals Obamacare, and that might, in your opinion, is not a good thing. I would say that I completely disagree with that, and I am very concerned about access to care for patients, whether they be patients who are receiving Medicaid or Medicare patients. I think that is really what is in jeopardy here, and quality of care. Those are some of the things that we have got to be addressing and looking at. We're all talking about pay for, and that's very, very important, but it's really access to care and quality of care. So having said that, the discussion about the states and the governors who have decided to or been opposed to expanding Medicaid is an issue. In North Carolina, for instance, Governor Pat McCrory, has not elected to expand the Medicaid program, and his quote is, "Our Medicaid system is broken, and I cannot expand a broken system." Now, I understand the governors that have, but I also understand that it's also information that they're receiving, and good intentions are, I think, what is happening here. And I would just like to cite, I know there were some other studies that were being discussed about how, and you had made comments that someone who is put on Medicaid essentially will receive the same health care and the same quality as someone who is on a private health care insurance plan. And I would dispute that. In fact, the study that I most recently became familiar with is the 2010 University of Virginia study, which released a landmark study showing the surgical patients, and this is surgical patients that they cite, on Medicaid have a 13% higher chance of dying than an individual with no insurance at all. Keeping in mind, of course, that the death rate or the mortality of a surgical patient with health care insurance is about 1.3%. So that's statistically pretty small. But 13% higher than someone with no insurance at all, and 97% higher if that person is on Medicaid. Now, that is in stark contrast with some of your theories and basically some of the studies that you've already cited. Having said that, obviously this study shows, yes or no, that putting someone on Medicaid is not necessarily giving them better health care. It is. Okay. Now, were you familiar with the study?
My understanding of that, or of similar studies, I'd have to check that particular, is that it is of considerable importance when you do a study to compare costs under different insurance programs, that you recognize the health status or differences in the health status.
And I believe this study actually does that. So I would encourage you. I would encourage you to familiarize yourself with this particular study because it breaks it down.
Now, having said that,
how can you justify, Medicare, how can you say to an individual that would be put on Medicaid as a result of the expansion of Obamacare, essentially, how can you say to them that you really feel that they're going to be getting better health care?
Well, because I have a host of evidence that shows that people who get Medicaid have better access to care than people who without health insurance, and that they live longer as a result. I'm very comfortable in making that judgment.
So, in your opinion, putting more people on Medicaid is really the answer, not necessarily forward a bit, passing a bit, that pro-growth economy people off Medicaid?
I actually, Mrs. Ellen, that is a statement. What you're talking about is the expansions in the Affordable Care Act, which I think will be of huge benefit to the population, whether through Medicaid or through exchanges, and I thought all with the value to their populations and go along with that expansion.
Mr. Archambault, why? What? Are you familiar with the Virginia University of Virginia?
I am. Yeah.
Why is it that when patients are put on Medicaid that there's this discrepancy? Because there would be this natural assumption that if you're put on a Medicaid plan, that all of a sudden you're going to get better health care and you're going to have a better outcome.
Without specifics to the program in Virginia and how it's treated, I think what that study illustrates is that the history of under-reimbursing doctors has led to some unexplainable results on the program and inconsistent quality care being provided. And I'm not sure we fully understand why yet. There's a lot of theories, but consistently in the academic literature, we're seeing more and more examples in which the quality of care is less than those on private insurance.
Okay. Thank you very much, and my time has run out. I appreciate this testimony. Thank you.
Chair, thanks, gentlelady. That concludes the members' questions. At this point, if you have additional questions, you may submit them to the witnesses. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. This was an excellent hearing, excellent testimony. Thank you very much for coming today, and members should submit their questions by the close of business on Monday, April 1st. With that, the subcommittee is adjourned.